just content for the heck of it. It is actually meaningful. So this slide gives you our AI philosophy. We use AI to scaffold safety, empathy, equity, and ethics, not to erase any of them. Everything we build is governed, it is iterative, and it's frontline validated, and we look for small wins, not shiny tools. To summarize this, we focus on co-creation before computation. And for co-creation, we work with the teams on the ground. That's empathy, the first step of the human-centered design thinking process. So, and a very good example I can give you over here is the Equity in Emergency Care Program, or E2CP of ours, which was run across emergency departments. It started off with working with the teams on the ground, like I mentioned, emergency department physicians and nurses, and allied health and other folks, and improving the triage processes within the EDs, and then making them more data driven. So creating ED dashboards. And so the frontline people validated those dashboards. They were utilized to come up with those dashboards, as well as for utilizing them, adapting them, tweaking them, or even abandoning them if they weren't useful. So that was a very simple example of how our AI philosophy was actually rolled out. The second question asked of me was around trusting AI. How do we know that the trainings that we are giving are within a certain governance framework, if I may? So what are the guardrails, in other words? And so over here I emphasize that AI tools that we utilize are advisory, they're not autonomous. Each rollout that we have employed utilizing AI or any kind of technology or innovation has clinical oversight with an IRB-like ethics lens to it. Innovations are reviewed by frontline teams before deployment. Again, I'm kind of repeating what I said on the previous slide as well. But very importantly to us, compliance doesn't kill creativity. It actually enables trust. And to summarize this slide, we treat AI as scaffolding, not substitution. Every tool must earn trust before scale. In other words, we are scaling trust, not so much the tech, whether it's AI or something else. An example I can give you over here is of PDtails, which was an implementation in pediatrics. And we utilized generative AI to come up with storylines for children as a distraction tool. And these stories were created by our pediatric staff, doctors and nurses, even administration who were interested in storytelling. And we utilized university students as well in some of our countries. And so whatever stories that were being generated utilizing Gen AI were being run through the lens of governance, or ensuring that they were appropriate for those small children through pediatricians, through teachers, in school-based settings, and so on. So AI was not just popping out, or it's coming out with some output and some results which we were just utilizing as is. It was going through a very strict governance framework. Third question I was asked about was how do we ensure that change fitness sits well with the AI, or the other way around? How does AI fit well with the change fitness? So a few important highlights again. We do not scale technology, we scale trust. We scale trust and thoughtful care, and workforce capability precedes tool acceleration. So the workforce is upskilled first. And by change fitness, I am going to utilize that as an opportunity to talk about adaptive capacity. So change fitness is adaptive capacity, in other words, which implies that teams can adjust, learn, and sustain performance under pressure. Now, keep in mind that we are functioning in emerging markets of South Asia and Africa, West Africa and East Africa, and these are all volatile communities or populations or countries, all kinds of volatility and stressors. But our workforce is very adaptable. And so I think, and that's what's been my experience as well, that AI and other emerging technology sits very well with this ever-changing landscape. And so change fitness or adaptive capacity connects really well with this kind of AI. And an example would be the mood boards that we have devised. And through that, we can gauge happiness in the moment. So we do these events, which are called healthcare transformation movements, HCTM, or celebrations of that, could through a gala or a celebration or a mela, as we call it in Pakistan. And so we are able to gauge, we have a hand on the pulse of the mood of our staff that are attending these celebratory events, where they become the stakeholders of the healthcare transformation work that has been done. And then we use these mood boards, which has utilized AI to kind of help us generate these mood boards, as well as to analyze the data and to graph it out as well, and to have actionable insights. So I don't have time, but please get in touch with me. Asadai Mia is my handle for LinkedIn, and we've also published our data and presented it in various conferences. So I'd love to talk to you about it more. In conclusion, AI strengthens systems that are already very strictly or strongly governed in our platform. Learning cycles determine impact, and scale is of trust, not noise, not AI even. And to upscale, we really have to scale trust. And finally, human-defined need, which is empathy. That's the first step of the design thinking process, which leads to governed AI support, leads to embedded learning, which then leads to strengthened capability. And this becomes a cycle. So then that leads to more human defined needs, and so on and so forth. So it's really a continuous quality improvement cycle. And it helps us strengthen patient safety, patient quality, clinical excellence, staff engagement, even help us mitigate staff burnout. And all of these things impact the double bottom line of financial and social impact as well. Once again, thank you to the great, lovely hosts, and thank you for the opportunity, and thank you, Evercare, everybody across the platform, my boss, and my advisors, and my teams on the ground, who've been just fantastic in helping me implement these change processes, these healthcare transformation processes, and then just run with them. Thank you. Have a great day, and all the best.
Thank you so much, Professor Azad. I see that we're really running out of time. Dr. Oshunloye, I'd have loved to ask you one more question, but I'm going to respect everyone's time and just see if there's any burning question on the chat. Please, can my organizers read out just one burning question? And I think we'll promise that all other questions, when we're sending out the notes, we'll try to make sure that the speakers, the experts, respond to them, and they'll be sent out to you. So
Thank you.
Yeah.
Thank
Yes.
you, Dr. Kechi. Titi, Jamie, anything that you think we can raise? One question in the interest of time and before closing remarks. Really inspiring panel, Dr. Kechi. Thank you so much. Anything that Titi? There are quite a few exciting comments, I must say, and then we've been able to sort of respond as they go to the questions, but this is a recorded session, Dr. Kechi. Everybody will have the ability to look at the responses, but also interact on our platforms as need be. So I do recommend moving forward and putting closing remarks, because there was one actually comment at the end, which I found really interesting. It says, today technology information overload is quite daunting and overwhelming, right? So I don't know, but can we use AI to solve this issue? So as I'm listening to all these panelists and the different expertise around the AI, the different learning, it's like, how do we, compile that knowledge and experience and use cases into something really policy for, it's really data and evidence for policy making for Africa, especially, right? So how do we also make sure we build capacity to be able to generate our own AI, right? So we need instead of thinking how to adopt and and put it in context, how do we build the capacity in our youth, in our early professionals, in current clinical staff to actually develop the AIs that we need with our own data, with our own nuances. Dr. Thomas Manhattan, she was also saying it's nuanced, right? So how do we bring that nuance in, build it in, and be able for AI systems to talk to one another and build up, right? So the problem is already fragmented, too much information. So I just want to close and allow Professor Naogamahari to also do the closing on behalf of Anadash, just to say it was truly a pleasure to have all of you, Dr. Kechi. Thank you so much, all the panelists and the opening remarks. We cannot say enough of these sessions and what we learned. There is going to be another session coming up, part 4 of our series. But if I can allow Professor Naogal, please, to do also the closing on behalf of P2P, but on behalf on Anadash, Dr. Egbe, I think you can say hello if you're on, and Oma and everybody. Thank you so much for this wonderful, wonderful session. Professor Naogal? Is he on? I don't see him.
I think, Maraki, you're right.
Right? Dr.
You're
Egbe,
right.
please. I think he's off. Maybe you want to say a few warm hello to everybody. Thank you.
Okay, no, thank you very much for an amazing panel, and thank you to Dr. Maraki for organizing. And so we hope you will join us for the next one on April 22nd. And as Dr. Maraki mentioned, this will be on the website with all the recordings, and any sort of outstanding questions will be answered. But we hope you will join us on April 22nd for the next one, where we have some exciting speakers from Mayo, from the space station, and for folks who don't know, we do this every 2 months, and really the idea is really focusing on AI within the healthcare space. But we'd like to say thank you for all the wonderful speakers. We really appreciate your perspectives from the introductory speaker and from Vamshi, from just giving us a little primer on what we're actually talking about. And from the wonderful speakers of both sessions, we really appreciate you.